All right, our next speaker in the ILD series this afternoon is going to be Dr. Barry Shea of our ILD program here, who will be giving a talk on the diagnosis and management of CTD-associated ILD. Dr. Shea.
Thanks, Angie. It's a pleasure to be back at the pulmonary course this year, and thank you to all of you for joining us. Yeah, so for the next 35 or 40 minutes, we'll talk about some what I think are important concepts in connective tissue disease associated ILD. This is certainly a big topic, and there's no way we can cover all of the different aspects of CTD-ILD, so I decided to focus on a couple different areas. The first is about identification of connective tissue disease in ILD patients, particularly understanding that in some cases, interstitial lung disease can be the initial or perhaps the only manifestation of a connective tissue disease. And to talk a little bit about this concept of interstitial pneumonia with autoimmune features. And then the second sort of two-thirds of the talk will be focused more on some specific entities and really on the treatment of those entities. And those are sort of the three most common connective tissue diseases where we see interstitial lung disease, RA, scleroderma, and myositis. We'll review some of the recent International Society guidelines on treatment of CTD-ILD and progressive pulmonary fibrosis, and kind of leave you with this concept of should we be moving towards individualizing therapy for individuals with these fibroinflammatory interstitial lung diseases. So to start off, interstitial lung diseases are in fact very common in connective tissue diseases. There's a little bit of a push to rename the CTDs systemic autoimmune rheumatic diseases, or SARDs. So you'll see both of those. You'll see CTD and SARD both mentioned in this talk. But regardless of the connective tissue disease or the name you want to give them, ILD is very common. ILD occurs in up to 50% of patients with systemic sclerosis or myositis. It's a little bit less common in RA. About 10% of patients with RA develop clinically significant interstitial lung disease. Mixed connective tissue disease, sort of as an entity that has features of myositis and scleroderma, also has a very high incidence of ILD. In Sjogren's disease, it's been reported that up to 20% of patients develop interstitial lung disease. In practice, it seems like many of these actually have probably secondary Sjogren's disease and have a more complex connective tissue process. Lupus, in fact, ILD is quite rare in pure lupus. And most of the time when you see a patient with chronic interstitial lung disease and a diagnosis of lupus, they have something along the lines of mixed connective tissue disease or overlap syndrome. It is important in patients with connective tissue disease, particularly these entities that are higher risk for developing ILD, for them to be screened. This is from the recently published ACR and CHEST guidelines on screening and monitoring ILD in the setting of connective tissue diseases. And they recommend, this is a conditional recommendation, that patients with CTDs at increased risk of ILD are screened with PFTs and high resolution chest CT scans. And if ILD is discovered, they should be monitored at least every 3 to 6 months within the first year with PFTs and annual CT scans as needed. But truthfully, I feel like this part is actually not that complicated. Once a patient has a known connective tissue disease, it's not that hard to identify interstitial lung disease. We have PFTs, we have high resolution CAT scans. It's pretty easy to identify. I think as a pulmonary community, we have a much harder task when we are seeing patients with interstitial lung disease and trying to determine whether or not they have an underlying connective tissue disease. This oftentimes can be very subtle. So when we do evaluate patients with ILD, it's very important to look for features of CTD because they can be subtle. So these can be features based on the history or physical exam, Raynaud's phenomenon. Patients may not volunteer on their own. Some of these physical exam findings can be very subtle. Gotrin papules, telangiectasias, these can be very subtle, but they can be clues to an underlying connective tissue disease. We typically, when evaluating a new ILD diagnosis patient, will send off extensive serologies looking for further evidence of an underlying connective tissue disease, which you can see here. And then occasionally other supporting tests are needed, things like echocardiograms if there's concern for pulmonary hypertension, or other testing based on symptoms or the suspected underlying disease process. And then, as I'm sure many of you know, there are defined classification criteria for many of the connective tissue diseases. There are criteria for systemic sclerosis or scleroderma, or polymyositis dermatomyositis, for Sjogren's disease, and for rheumatoid arthritis. Um, but one of the things that's interesting is despite the fact that interstitial lung disease is so common in many of these connective tissue diseases, only in scleroderma is the presence of ILD included in those classification criteria. And it has been well described that interstitial lung disease can precede the onset of other manifestations of connective tissue disease, particularly in rheumatoid arthritis and in myositis. And I guess the question I would ask is, do we wonder if ILD can be, on some occasions, the only manifestation of an underlying connective tissue disease? So I'll show you a case. This is a patient I took care of many years ago, probably over a decade ago now. This was a 58-year-old man who at the time had been healthy, and he presented with 1 month of dyspnea, cough, and prominent constitutional symptoms. He had some night sweats, some anorexia, some weight loss. He had no rashes, he had no muscle aches, he had no arthralgias. And this was his CT scan on presentation. He had these diffuse bilateral ground glass and peripheral areas of consolidation. He was quite sick, and he rapidly progressed to respiratory failure, required intubation. All of his microbiological studies were negative. He did not improve with antibiotics and diuresis. He ultimately underwent a lung biopsy that showed florid organizing pneumonia with some other areas of non-specific interstitial pneumonia, or NSIP. And ultimately, his serologies came back positive for anti-OJ antibodies. All of his kind of preliminary serologies, ANA, ANCA, JO1, rheumatoid factor, were all negative. But he did have the strongly positive anti-OJ antibodies. This is one of the anti-synthetase antibodies that is thought to be very specific for polymyositis or dermatomyositis. And he was treated with high-dose steroids and transitioned to mycophenolate, and he did really well. This was a CT scan from probably a year later when he went back to kind of living a normal life without respiratory symptoms and working full time again. And he has done very well for many years since then. And I guess I would ask, well, what is his diagnosis? He had a interstitial lung disease. He had positive anti-OJ antibodies, but had no other manifestations of polymyositis or dermatomyositis. But that's exactly what I think this patient had. So polymyositis and dermatomyositis, the idiopathic inflammatory myopathies, this is an autoimmune disease or diseases characterized by proximal muscle weakness and muscle inflammation. When there is muscle involvement only, we refer to it as polymyositis. When there's both muscle and skin disease, it is referred to as dermatomyositis. And some of the classic skin manifestations are these Gotrin's papules, these violaceous scaling papules on the extensor surfaces of the hands over the joints, or the heliotrope rash, this violaceous rash on the upper eyelids. But it's also been identified probably, starting about 40, 50 years ago, that there are patients who have some of these classic skin manifestations of dermatomyositis, but don't actually have any muscle involvement. And these patients have been referred to as having amyopathic or clinically amyopathic dermatomyositis, and they make up about up to 20% of all cases. In the early 1990s, Ewer and Sontheimer proposed that what we are calling these different conditions are all sort of exist on a spectrum of muscle and skin involvement in this condition, dermatomyositis. One of the keys to diagnosing dermatomyositis has really been identification of the myositis-specific antibodies. So these are circulating antibodies that have been detected in polymyositis and dermatomyositis, not seen in other connective tissue diseases, not seen in healthy people. And these consist of the anti-synthetase antibodies, and JO1 is the most common and probably most famous of these antibodies. But there are several other anti-synthetase antibodies, including anti-OJ, such as the patient we just discussed, and then others as well listed here below. And some of these different antibodies are associated with different profiles, such as MDA5, which we'll talk a little bit about later, which has been associated with rapidly progressive interstitial lung disease. So when I was at Brown, one of the things we were interested in looking at is how common is interstitial lung disease compared to muscle disease and skin disease in patients with these autoantibodies. So we took somewhat of an agnostic approach. This was with a fellow who was working with me at the time, Avi Misra. We decided to look at all the patients who had positive myositis-specific antibodies over, I think this was a 4-year period, and just look and see how common interstitial lung disease was compared to muscle and skin disease. We identified 3,000 patients that were tested. a total of 40 patients who had positive myositis-specific antibodies. Again, Jo-1 was the most common one, but it still made up only about a third. The other two-thirds were these other myositis antibodies. And interestingly, when we looked, we found that lung disease was the most common manifestation. So over 80% of these patients had interstitial lung disease, whereas only 40% had muscle involvement and about 30% had skin involvement. And interestingly, half of these patients, 50% of them, had isolated interstitial lung disease with myositis-specific antibodies without evidence of myositis or skin involvement. And so I think that we need to rethink, particularly this condition, polymyositis, dermatomyositis, but other connective tissue diseases as well, and really incorporate the lungs. And we've sort of proposed this non-proportional Venn diagram of looking at muscle involvement, skin involvement, and interstitial lung disease in this condition that we might call dermatomyositis. We've proposed the name dermatopneumomyositis, but I think whatever you call it, these myositis-specific antibodies can help identify some of these individuals that might otherwise be missed. Another useful way to think about these types of patients is kind of under the umbrella term interstitial pneumonia with autoimmune features. This came out of a joint task force from the ERS and ATS that was looking at patients with interstitial lung disease of unknown cause that didn't have meet defined criteria for connective tissue diseases, but had features suggestive of autoimmunity. And so they proposed this term IPATH. This was meant to be a classification criteria, really to better define and try to study and understand these entities. But I think, like with many classification criteria, they tend to get used as diagnostic criteria. And this was this is a summary of their proposed criteria. So to meet criteria for IPATH, patients have to have interstitial lung disease of unknown cause, and not meet criteria for defined connective tissue disease, and then have at least one feature from 2 out of 3 domains. A clinical domain that was sort of symptoms or signs that are suggestive of connective tissue disease. That could be Raynaud's, it could be inflammatory arthritis. Serologic domain, these are autoantibodies that are highly suggestive of, or in some cases specific for connective tissue disease, and a morphologic domain. So specific patterns of interstitial lung disease, most notably organizing pneumonia, NSIP, LIP, or other intrathoracic abnormalities that were suggestive of an underlying connective tissue disease, like unexplained pulmonary vascular disease. So patients need to have at least 2 of these 3 criteria. I think in simpler terms, this is patients with specific patterns of idiopathic interstitial lung disease. And importantly, they excluded the UIP pattern here very intentionally. Because with the UIP pattern, the pretest probability is higher that these patients may have idiopathic pulmonary fibrosis and not connective tissue disease. For patients with these specific patterns of idiopathic interstitial lung disease and certain clinical or serological features that are suggestive, but not diagnostic for connective tissue disease. So let's move on to treatment. And I think one of the important things to keep in mind when we're thinking about treating CTD-ILD is that this is really a heterogeneous group of autoimmune diseases and heterogeneous pulmonary pathologies. So as you can see here, the different types of patterns of ILD that can be seen, the most common one certainly is the NSIP pattern, which is shown in light gray in these bars. But UIP is not uncommon, particularly in rheumatoid arthritis, and other patterns can be seen as well, such as organizing pneumonia or LIP. And I think it's a bit of an oversimplification, but it generally holds true. If we think of UIP as the most fibrotic of these different entities and the least inflammatory, and organizing pneumonia or LIP being more inflammatory and less fibrotic, the response to treatment tends to correlate with the more of the inflammatory response and not the fibrotic response. RA ends up being a really interesting CTD to study, or RA-ILD, because of this kind of heterogeneous patterns of ILD seen in that particular entity. So RA is the most common of the connective tissue diseases. ILD occurs clinically in about 10% of all RA patients. If you look at autopsy series, it's even higher, close to 30%. And it has been well described that the ILD can precede the onset of joint disease in RA, sometimes by years. Some of the main risk factors are older age, smoking. There are some genetic abnormalities that have been associated with development of ILD in RA. including the MUC5B polymorphism, which is known to be a major risk factor for developing idiopathic pulmonary fibrosis. And it's been shown that those patients with the UIP pattern, again, that is the pattern that we see in idiopathic pulmonary fibrosis, even when we see it in RA, it confers poorer prognosis. So this is a study published several years ago now, looking at RA-ILD patients with a UIP pattern versus a non-UIP pattern. And you can see that those with a UIP pattern had poorer survival than the non-UIP patients. And in fact, the RA-UIP patients behaved similarly to the idiopathic pulmonary fibrosis patients, suggesting that perhaps when there's a UIP pattern, it may not really matter so much what the underlying diagnosis is. There are unfortunately no good randomized control, no great data, certainly not prospective randomized data supporting treatment in RA-ILD. It's generally been assumed over the years that these patients should respond to immunosuppressive therapy. And there are several retrospective studies and some small studies or uncontrolled studies that have suggested that immunosuppression may be helpful. This is from, I think, one of the best retrospective studies that I've seen. This was published just a couple of years ago by Joyce Lee's group from the University of Colorado. They looked at over 200 patients with RA-ILD from 5 different centers. And they looked at the effects of immunosuppression. So it's either mycophenolate, azathioprine, or rituximab. And this is a pre and post analysis. So they looked at lung function before starting treatment and then after starting treatment. And they saw that initiation of immunosuppression correlated with what appeared to be stabilization of lung function, both looking at FVC percent predicted and TLCO percent predicted. And what was particularly interesting is it didn't seem to matter whether these patients had a UIP pattern or a non-UIP pattern. On the left here are the RA-ILD patients with a non-UIP pattern. You can see there's appeared to be stabilization of lung function associated with the initiation of immunosuppressive therapy. And also on the right here, those with a UIP pattern, which we would think might not be as responsive to immunosuppressive therapy, but we saw a similar effect. There's been a lot of interest in antifibrotics for treating RA-ILD, again, because of the predominantly fibrotic nature of the lung disease in many of these patients. There are, I'll show you a couple of studies here that included RA-ILD patients. These are data from the INBUILT trial. This was a randomized controlled trial of nintedanib versus placebo for progressive fibrosing interstitial lung diseases of many different types. A small percentage of these patients in this trial, 13%, had rheumatoid arthritis ILD. And the overall patient population, they saw that nintedanib slowed disease progression as measured by FVC compared to placebo. There was a study, randomized controlled trial of pirfenidone for RA-ILD, specifically for RA-ILD. This is a TRAIL-1 study. This is a phase 2 study. Unfortunately, this was stopped early after enrollment of only about half of the planned total. This was due to the COVID pandemic and slow enrollment. And it unfortunately did not meet its primary endpoint of categorical decline in FVC by 10% or more. There were numerically fewer of those patients in the pirfenidone group versus the placebo group, but this did not meet significance. Interestingly, their secondary outcome was absolute decline in FVC, which is usually used as a primary outcome in these types of studies. And when looking at this secondary outcome, there was an effect of pirfenidone on FVC decline that seemed to be driven largely by the patients with the UIP pattern. So I think about 2/3 of the patients in this trial had a UIP pattern. And you can see that in that subgroup with UIP, pirfenidone treatment was associated with less lung function decline over the course of the trial. So what sort of an overall approach we can take to RA-ILD treatment? There's, as you'll see at the end, there are some guidelines now that we can use to help us make these decisions. For the most part, patients with mild disease who are asymptomatic and stable probably don't need to be treated. However, those who have more severe disease, have clear progression, or are symptomatic, probably warrant treatment. There's this idea that perhaps patients with more inflammatory types, organizing pneumonia or NSIP, may be more responsive to treatment, and maybe we should be more inclined to use immunosuppression in those patient populations. A general approach is starting with steroids, typically at up to mg per kg per day, followed by a slow taper, and then as needed, adding steroid-sparing agents. Typically, mycophenolate or azathioprine or rituximab can be used as well. One of the challenges with RA is that mycophenolate tends to not be that effective for the joint disease, um, whereas many of the things that are effective for joint disease in RA are not tend to not be effective for the lung disease. Refractory disease, tocilizumab, cyclophosphamide, or combination therapy have been used. In patients who have progressive fibrosis despite immunosuppressive therapy, an argument can be made for adding nintedanib, perhaps pirfenidone also, and you can see that those are both included in the guidelines that were published recently. And then, of course, clinical trials and lung transplantation have to be considered as well. So let's move on to scleroderma. So scleroderma or systemic sclerosis is a connective tissue disease where ILD is very common, up to 40 or 50% even have interstitial lung disease at some point over the course of their illness. It's more common in those with diffuse cutaneous involvement or those that are anti-SCL70 positive, but it can really occur in any subtype of scleroderma. And when present, ILD is associated with a poor prognosis. Less than 50% survival at 10 years with all comers with scleroderma ILD. And this from the right was from a Norwegian registry of all of the residents in that country with scleroderma over a 12-year period. About 50% of patients in that registry had interstitial lung disease on HRCT scans. And what was interesting is even in the patients with preserved lung function at baseline, so these were in patients with vital capacity greater than 80% predicted, the presence of fibrosis at diagnosis was correlated with poor survival. So ILD is really, really important in scleroderma. For many years, the mainstay of treatment was cyclophosphamide. This is based on the SLS study that was published in the New England Journal almost 20 years ago now. This is a randomized controlled trial of cyclophosphamide versus placebo in scleroderma lung ILD. And what they found, although the treatment effect was modest, there were more patients treated with cyclophosphamide that had improvement in their lung function compared to placebo, about 50% versus about 25%. Again, the effects were modest, but it did seem to have a beneficial effect. That has since really been replaced by mycophenolate as our first line therapy for scleroderma lung disease. And this is based predominantly on the SLS2 study that was published now about 10 years ago. This was a phase 3 randomized controlled trial of mycophenolate versus cyclophosphamide in scleroderma lung disease. There was no placebo arm here because cyclophosphamide was considered standard of care. And in both groups, both mycophenolate and cyclophosphamide resulted in improvement in lung function over the course of the study. You can see this is FVC percent predicted. And if you look at the categorical increases in FVC, again, it was about 65 or 70% of patients in both groups had improvement in lung function over the course of this study. But mycophenolate was better tolerated, had less toxicity, fewer patients discontinued treatment. So this has really become kind of the standard of care now for scleroderma lung disease. There's been a lot of interest in tocilizumab in scleroderma as well, and this much of this is based on the FOCUS trial. It was published just a few years ago. This was a randomized controlled trial, phase 3 RCT of tocilizumab versus placebo. But the target population here wasn't interstitial lung disease. This was a diffuse cutaneous scleroderma. These are patients had relatively recent diagnoses. They had elevated inflammatory markers. About 2/3 of these patients had interstitial lung disease, but having ILD was not a prerequisite for study entry. The primary endpoint in this trial was improvement in skin disease, and tocilizumab failed to meet that primary endpoint. It did not seem to be effective for the skin disease. When they looked at lung function, here this is based on FVC over the course of the 48 weeks of the trial. You look at all patients in the trial or just at those 2/3 of patients who had interstitial lung disease, tocilizumab seemed to prevent the lung function decline in this patient population. And based on these data, despite the fact that this was a secondary outcome, tocilizumab was approved by the FDA for treatment of scleroderma ILD. And I think one of the things to keep in mind, of course, whenever we look at some of these trials, including of scleroderma, we see these graphs showing lung function decline. And we think of scleroderma lung disease as always this progressive disease, but it isn't always. There are patients who get better with treatment. This is a patient that I cared for several years ago. She was 57 at the time of diagnosis. She had actually presented with Raynaud's phenomenon and finger swelling. She found a strongly positive anti-RNA polymerase III antibody, so she met criteria for a diagnosis of scleroderma. She had screening PFTs that were mildly abnormal and a screening HRCT scan that showed these mild bibasilar peripheral ground glass opacities. And she didn't really have any respiratory symptoms at that time, but because of her skin disease, she started on mycophenolate. And then 9 months later, her PFTs and her CAT scan had both improved. So there was clearly reversibility to her interstitial lung disease in this patient with early, predominantly skin manifestations of scleroderma. On the other hand, there are patients who seem to progress despite aggressive immunosuppressive therapy. So this is another patient. He was 68 at the time of diagnosis. He presented really with respiratory symptoms. He had about a year and a half of progressive dyspnea. He had a CAT scan done that showed evidence of interstitial lung disease with an NSID-like pattern. These bibasilar ground glass opacities, traction change, subpleural sparing. And on his evaluation, he admitted to longstanding Raynaud's phenomenon. And on exam, he had swelling of the digits, he had diffuse telangiectasias, and he was found to have a positive anti-SCL78 antibodies. So he was diagnosed with scleroderma and scleroderma-associated ILD. He was treated aggressively over the next several years with low-dose prednisone, mycophenolate, eventually rituximab, but unfortunately, he continued to progress and ultimately died from progressive lung disease. So there are patients that, for whatever reason, have a predominantly progressive fibrotic phenotype with scleroderma. And for this reason, there was interest in studying antifibrotics in scleroderma lung disease. This led to the Census trial, which is a phase 3 RCT of nintedanib versus placebo in patients with scleroderma ILD. And as we saw with idiopathic pulmonary fibrosis, and as we saw with progressive pulmonary fibrosis of undifferentiated types, nintedanib slowed lung function decline in scleroderma lung disease. And one of the things that I found sort of particularly interesting was looking at the effects of mycophenolate and nintedanib together in this study. So patients in this Census trial were allowed to be on mycophenolate at baseline, and it turns out about half of the patients were on mycophenolate, and it was evenly split in the nintedanib and placebo groups. And if you look at the patients that were on mycophenolate at baseline versus those that were not on mycophenolate, the absolute change in FVC was similar to the effect that we saw with nintedanib alone. And in particular, if you look at the patients who were on mycophenolate at baseline and received nintedanib, they had the least lung function decline of all the different groups. This decline of FVC of about 40 mils over a year is sort of similar to what we expect to see with normal aging. So perhaps in some patients, this combination anti-inflammatory and anti-fibrotic approach may be appropriate. So, so much like with rheumatoid arthritis, the indications for treatment in scleroderma lung disease tend to be those with symptoms, those with documented progression, or those with moderate to severe disease. There is some thought that treating patients earlier may be preferable to treating them later because we're perhaps getting a more early inflammatory part of the disease process, but we don't know that for sure. MMF is generally considered the first-line therapy for scleroderma lung disease. Tocilizumab is considered a suitable alternative. Again, keep in mind that those were based on a secondary endpoint in their trial. And then some alternatives are second-line agents, rituximab and cyclophosphamide, and even stem cell transplant in some cases. For those patients who continue to progress despite mycophenolate or other immunomodulatory therapy, nintedanib is certainly a reasonable option as add-on therapy. And then, of course, always consider other potential complications, whether GERD could be contributing, whether there's pulmonary hypertension, and of course, given the complexity of these patients, like all of our CTD patients, collaboration with our colleagues in rheumatology is really, really important. Lastly, let's move on to interstitial lung disease and myositis. As with scleroderma, ILD is very common in this patient population. A lot of studies report 20 to 40% incidence of ILD. Some studies have reported up to 80% of patients with dermatomyositis may have interstitial lung disease with aggressive screening. And there seem to be two sort of distinct but potentially overlapping clinical patterns of ILD in myositis. The first are those patients that present with subacute or fulminant disease. They show up in our ICU with respiratory failure or ARDS of unclear etiology, like the patient I presented to you earlier. And then there's other patients who seem to have chronic progressive ILD that can be mistaken or mimic IPF, at least clinically. although again, these are not always completely distinct from each other. And a variety of different patterns can be seen, of course. UIP pattern has been described, but predominantly we see NSIP, organizing pneumonia, and in the acute phases, sometimes diffuse alveolar damage. And as we discussed, ILD in many cases can precede the onset of muscle and skin disease. And we think that at least in some cases can be the only manifestation of this disease process. Um, Again, much like the other connective tissue diseases, we really don't know exactly who should be treated and who doesn't need to be treated. Some have argued that really anyone with clinically relevant interstitial lung disease with myositis should be treated because perhaps this is an ILD that's more responsive to treatment than other types of CTD ILD. And we think that may relate to the fact that a lot of these patients have inorganizing pneumonia or organizing pneumonia and NSIP sort of overlap. Patients with anti-synthetase antibodies or anti-MDA5 are thought to be at high risk for disease progression and may be indications for treatment as well. There's a lot of small studies looking at different treatment approaches for myositis-associated ILD without really any good randomized controlled trials. Standard of care is generally considered high-dose steroids to start, followed by a taper. These patients almost invariably need a second agent and sometimes even a third agent, with mycophenolate, azathioprine, methotrexate, tacrolimus, rituximab all being reasonable options. For those patients with progressive pulmonary fibrosis, again, nintedanib can be considered. And then sort of unique to the myositis group are these patients who present with acute respiratory failure. And in those cases, high doses of IV methylprednisolone, like pulse dose methylprednisolone, is often recommended, sometimes with IVIG, and then using the different treatment strategies that are listed above. Anti-MDA5 disease, anti-MDA5 was just identified really in the last probably 15 to 20 years. Makes up about 10% of cases of dermatomyositis. These are often amyopathic dermatomyositis, and this has been associated with rapidly progressive ILD and a poor survival. And there have been some studies, again, not controlled studies, but that these have suggested that aggressive combination therapy up front may result in better survival than kind of a step-up approach. But again, these are not prospective randomized controlled studies. This is a nice summary of proposed approach to treatment of myositis ILD by Drs. Rob Hallowell and Sonia Danoff, published just a couple of years ago in Chest. Again, patients with mild disease with preserved lung function perhaps can be just observed. However, if there is progression or if patients have more moderate or severe disease, those patients should typically be started on high-dose steroids followed by a taper, along with a steroid-sparing agent up front, typically mycophenolate or azathioprine, with consideration of either transitioning or adding a third agent for disease progression, such as tacrolimus or rituximab, and then sort of a proposed approach to patients with acute fulminant disease, including pulse-dose solumedrol, IVIG, and one of the other immunomodulatory therapies. And then just to bring your attention to these were just published just last year. These are the 2023 combined American College of Rheumatology and Chest guidelines on treatment of CTD ILD. I encourage you to look at these documents. They are very comprehensive. There's a lot of information in there, and I think, as you might expect, because there's a lot of different immunomodulatory therapies, we're talking about many different disease processes, and even among those different diseases, such as rheumatoid arthritis, there could be several different sort of phenotypes. But a couple things I want to highlight in these guidelines as sort of general approaches. These are all in green here. These are all conditional recommendations. So none of these are strong recommendations based on the quality of data. The only real strong recommendation they made was a strong recommendation against steroids for systemic sclerosis. But in all other connective tissue diseases, they've recommended a combination approach with steroids and immunomodulatory therapy up front for CTD ILD. And you can see the different agents that were recommended as possible first-line agents. These are listed in order, in sort of rank order for the number of votes they received. And you can see that kind of across the board, mycophenolate was typically voted with the most drug that was voted for the most as first line for connective tissue disease ILD. with azathioprine and rituximab also being considered pretty much across the board. There were conditional recommendations against things like leflunomide or methotrexate or TNF-alpha inhibitors as first-line treatment. There were conditional recommendations against antifibrotics, pirfenidone or nintedanib, as first-line treatment, but those were included in second-line agents. So for patients with progressive therapy despite progressive ILD despite first-line therapy, options were considered either switch or add therapy. And again, this may depend on the individual situations, whether you decide to switch or add therapy. Probably for myositis, most would be inclined to add therapy. For something like systemic sclerosis, they might be more inclined to switch therapy. I think most people would, if they're using cyclophosphamide, would use that as a single agent, whereas others can be combined. You can see here nintedanib was considered a therapy option for progressive disease despite first-line therapy across the board. And again, mycophenolate, rituximab were all sort of options here. Myositis included some other drugs that weren't really considered in some of the other agents, so calcineurin inhibitors like tacrolimus, IVIG, JAK inhibitors were all considered options for progressive myositis. And then around the same time, the International Respiratory Societies came out with this consensus statement on progressive pulmonary fibrosis, and I think sort of gave a similar message about connective tissue disease, ILD, in addition to other progressive fibrotic interstitial lung diseases. This is for non-IPF ILD, and their recommendations are that nintedanib or antifibrotic therapy should be reserved for patients with progressive pulmonary fibrosis, including the CTD ILDs who fail standard management. And they acknowledge that standard management can differ from patient to patient. In many cases, it'll be immunosuppressive therapy. But the general recommendation was that antifibrotic therapy, in this case nintedanib, be added only when patients have failed standard of care, understanding that standard of care may vary quite a bit from region to region, and there's not always great evidence for this. I think ultimately we are moving towards a slightly more nuanced approach to treating what I like to refer to as fibroinflammatory interstitial lung diseases. I think for decades, really, we've thought about interstitial lung diseases with this framework. We think that there's some lung injury. In this case, for CTDs, we think it is the immune system attacking the lungs, and that's triggering an inflammatory response, and that inflammation is causing fibrosis. And if we can block inflammation with immunomodulatory therapy, we may be able to improve the lung disease and prevent further progression of fibrosis. And in some cases, this may in fact be true. We see this sometimes in scleroderma. But in other cases, for reasons that are unclear, it seems like the inflammatory and fibrotic responses to lung injury are uncoupled from each other. They may interact somewhat, but they really may be in parallel rather than in series. And in some of these cases, we really have to decide, is the fibrotic response or the inflammatory response dominating? Is there both? And do they need combination therapy for their ILD? So I will summarize kind of a lot of material that we covered. Keep in mind that interstitial lung disease is a very common manifestation of connective tissue diseases, particularly scleroderma, myositis, and rheumatoid arthritis, along with overlap syndromes. Patients with connective tissue disease that are at increased risk of ILD should certainly be screened for ILD. But I think for us as a pulmonary community, perhaps more importantly, we have to understand that patients with ILD should be screened for connective tissue disease, because sometimes ILD can be the initial and perhaps the only manifestation. And keep in mind that in CTD ILD, there's really a spectrum of patterns of disease, and consider both the fibrotic and inflammatory components when determining the optimal treatment approaches. It's hard to really summarize treatment of CTD ILD with just a few bullet points, but I think keep in mind that for most CTD ILDs, we should be considering steroids and steroid-sparing agents as first line, except in scleroderma, where we tend to avoid steroids because of the theoretical risk of precipitating a scleroderma renal crisis. Some disease-specific things to consider are tocilizumab for scleroderma, IVIG and calcineurin inhibitors for myositis ILD, and then, of course, antifibrotic therapy for those who progress despite standard of care. And I will stop there. Thank you very much.